elements. And again, I encourage you to download on-call antibiotics. It's the only and first antimicrobial game developed, but we also have included behavioral nudges, thinking about not just education, thinking about that social component, that behavioral component, psychological component, okay? It may be that networking and fostering networks of nurses will help, and we have already established, together with ICANN and BISAC, some links with African countries, African organizations to see, what are they doing, what are they learning about, what do they need to learn in terms of antimicrobials. And this just sort of reflects the event when we presented there, or nurses presented there, about the role that they could have or we could have in terms of antimicrobials. And finally, I think that the leadership aspect really needs to be resolved. And to me, it's always fascinating to think about this quote, isn't it? So that was May 1961, and President Kennedy said, before the end of the decade, we will have a man on the moon. So under 3,000 days from that sentence, there was a man on the moon. There was no space program, but there was a vision. And perhaps we're coming to the point where we may be able to have that vision, that moonshot, as I call it, of nurses taking part at a much higher level on antimicrobial decisions around the world. And this nurse has just replaced the Surgeon General. This is the highest public health figure in the US government. And I do think that we may be getting to this point where the labels will disappear and the best possible person may be able to influence decisions about antimicrobials. And we have tried as well to influence that leadership by developing and organizing the first International Nursing Summit on Stewardship, where we had colleagues from South Africa, Norway, Scotland, the UK, selected group of decision makers, key decision makers that can make things happen. Not clinicians, or not clinicians only, but key decision makers. And just to finish, perhaps it's time to move on from that bedside perceptions of what we can do and suggest that nurses could have a much greater role in the design, the implementation, and the execution, and the monitoring and the evaluation of antimicrobial stewardship programs. Perhaps the time is right and the time is now. So to sum up, I hope that I haven't sort of overrun. It's good. But my belief is that antimicrobial stewardship programs have to consider the participation of other healthcare professionals, other professionals, citizens, of course, social care, many other levels. Perhaps I may have convinced you that the participation of nurses in this process up until now has been suboptimal and focused on clinical aspects, and there's more to it. And I think that before we embark on any of these transformations, we really need to evaluate how organizations are primed, what culture they've got towards the implementation of these new ways of thinking and doing related to antimicrobial stewardship. Thank you ever so much.
Thank you very much, Enrique. Thank you. So Enrique sort of took us through really the sort of exciting future for the nurse role in antimicrobial stewardship. And actually in Cornwall, we've sort of embarked on that with our drug and bug nurses, and they've done a fantastic job delivering antibiotic stewardship interventions in care homes. And sadly, the sort of funding for that is coming to an end. So that's my first question really, is around that. So we know in Cornwall, and you know through your work, that there's a great role for nurses to deliver antibiotic stewardship roles. But the funding doesn't seem to be there, or we can't find it. So is there any sort of work going on nationally to try and sort of put some money in a pot, really, for that sort of role?
I think that one of the fundamental problems that we've had and we've got is about demonstrating that, value for money makes me always uncomfortable, because I'm never sure what value means, or the many flavors that value can have, and nurses and nursing teams and the teams that have supported nurses haven't really published evidence about the impact. And it's very difficult to go to a commissioner to say, we're fantastic, we've done a great job, but but I cannot really show you what that job is, or the areas where we may have focused on. They're very nice, very necessary, but again, it's very difficult, particularly now, where every pound is much more worthy than before.
Yeah.
What was the impact? And it's sad that we have to focus on hard impact rather than satisfaction or quality of care.
Yeah. Well, we have some hard impact. We just need to get it published, don't we? So before
So I do think that is fundamental, and we need to kind of collaborate and work together and develop the networks where we can put out there the evidence. We also need to be happy that if the evidence is not there, if an intervention that we carry out didn't produce any results of value, we need to drop it. But I do think that nurses, we still haven't published enough, or we haven't worked about evaluating these interventions. And I think that experiences like you guys in Cornwall are wonderful and need to be out there, so then we can say, this is the value for money, or this is the value, and this is the money that costs it. Give us more.
Yeah, okay.
Or give you. Or
We've
give
got a
more.
bit of time for that, haven't we? Not much. Okay, any questions, please?
Thank you for an excellent talk. I'm based at the University of Bristol, farm there, and I work quite closely with farmers, farmers, and trying to empower them to make change on their farm. So what you were talking about with the nurses, taking more advocacy role, and being empowered to guide and lead on this sort of in my head. How would you suggest nurses, farmers step up to possibly top down a system, a very authoritarian system like clinicians or vets, to take more of a role in antimicrobial stewardship?
I mean, we have seen some of the evidence from Cochrane reviews about which kind of, punitive or nudging measures have got more impact on prescribing behaviors. I think that the time for sort of education and punitive measures, there may be an impact for how long can you sustain behavior change if you just focus on figures and education and authoritarian positions. I am not a great believer of that, really. I think that humans are much more complex, and whilst you may achieve changes related to including those upper levels, I don't think they're going to be sustainable. And the beauty of some of the qualitative work that we have been conducting at Imperial is that it has allowed us to understand about the social networks of prescribers, and social networks as in the relations between them. And of course, with animal health, I think that it would be naive to not consider the economic impact, isn't it? When a farmer is making a decision about using an antimicrobial on an animal or an animal group, I do think that there is an economic behavioral rationale that we don't have in a hospital or a GP practice, isn't it? And perhaps we really need to be much more finesse about how we think that humans will use a resource such an antibiotic when they are against economic decisions. So I think that we have got beautiful qualitative work to do about that decision-making process. And altruism. I mean, we are developing a program of research at our center, trying to understand the value of altruism, because I think that we're coming to the point where the gain of every individual by using antimicrobials may be smaller compared with the negative impact on their community, isn't it? And we need to really understand at which point humans will give up that marginal gain for themselves versus the marginal impact or the negative impact on their community.
Really just a question and an observation. Do you do any work with the veterinary side of things, like with veterinary nurses?
Not currently, because we're focused on human health or sort of different kind of mammals' health. So we don't do any current work on with vets, although we have got some links with some vet schools, but we don't do any current work.
I mean, one of our problems, I think, in veterinary medicine is that we don't have a nurse practitioner status, and I think it's a trick we're missing. Our overriding legislation for veterinary surgeons is 51 years old, and we are starting some consultations to review that. I think one of the things that we need is a bit of upward pressure, because our nurses have no autonomy to do pretty much anything, and that's within the framework that we're able to work with. I think really we need some outside agencies to put pressure on the Royal College very soon to actually enable our nurses to develop their roles.
Yeah. And I mean, perhaps that's a situation that it's currently in place in many countries related to nurses for human health, isn't it? When I'm giving this talk in other places, they tell me, oh, but nurses don't do anything, nurses don't know anything, nurses are still at a very non-autonomous stage, and I fully accept that. Again, that's why we suggested that we need to evaluate at which point of maturity organizations or systems are to be able to consider the adoption of these new figures or models, because it would be unfair to push for a particular model if the system or the organization simply is not there, and we need to work on the wider determinants of the organization.
Got a question at the front, Sarah?
A really brief one. Is this with a requirement for altered culture and thinking, is this being driven through nursing education, formally?
Well, so we published our paper in 2016. We had presented some preliminary data in 2015. The Health Education Authority, HEE now, has recognized that dramatic gap in the education related to antimicrobials and antimicrobial stewardship. And we are working together with agencies to be able to influence the curriculum at a national level, at European level, and with WHO at global level to try to increase that. So it has been recognized, but it's only because we had the evidence to be able to say, look at the gaps. Don't expect clinicians when they are on the first day at work to have a fantastic knowledge of AMR, antimicrobial resistance and stewardship, if they only had 15 hours in the whole degree about this particular aspect. How can you expect that? And again, we have conducted some studies with postgraduate education highlighting similar gaps where clinicians or trainee clinicians get very little and very scattered, and therefore it may be unfair to expect them to have skills from day one at work.
Before we go over that, I just want to ask a quick question, Enrique. So we sort of got wind through the University of Plymouth Nursing School that antibiotic stewardship is not a recommendation from the Royal College of Nurses to be part of higher education institutes' curricula, which I was kind of sort of surprised at. Is that true? Have you come across that?
I haven't come across that particularly, and that sort of positioning statement from the Royal College of Nursing was published in March 2014.
Yeah.
I mean, it's fair to say that currently they're very supportive of all the AMR work,
Yeah.
but perhaps it would be surprising if that was their position. I mean, certainly with our study, we ask about, do you teach AMS, but also we ask which of these components are included in your curriculum.
Yeah.
So it wasn't, but it would be surprising to
So
learn.
off the back of that study, we've sort of asked our local sort of higher education institutions whether they do teach antimicrobial stewardship as part of their course, and our sort of representative from Plymouth Nursing School said currently they don't, and that was one of the barriers was the Royal College of Nursing. But I just wanted to ask. They're fine. I'll find out more. But
that would be disappointing, I would say.
before you do, sorry. Oh.
I just want to comment on that. There are
sure.
huge changes. We are awaiting Nursing and Midwifery Council standards that are due out any time now for our new curriculum.
Yeah.
And there's a lot of change, including nurse prescribing at the point of registration, which I think is going to change things. That's one of the suggestions, whether we haven't seen the standard yet, but I think these things are being recognised, and it's the Nursing and Midwifery Council that impose these things on us.
Sorry.
And they're kind of, so we have things implicit within certain things rather than explicit, but certainly when these standards come out, I think there are going to be huge changes. And also looking at the differentiation we need to have with the registered practitioner as opposed to all these other roles that are coming on board.
Yeah.
So there's a lot of things that I think are going to change in the next 12 months.
Thank you.
And hopefully to our advantage in this respect.
But it will be interesting to think about unintended consequences as well, isn't it, of those interventions? Because I always think that you kind of have everything may have an unintended consequence that we haven't planned. And again, it's going to be exciting to think about the connections between the different practitioners and the prescribing, or if it's prescribing, or in the terminology is still okay. Wow.
Hello, Judy McKinnon. I'm a ward manager of the community hospital. Nursing is my day job, and I have a viewpoint that this is all of our responsibility. I do support the role of the specialist nurse, but actually this is one of many things that we have to consider every day. And within, I think you're right, a multidisciplinary team. So actually, I'm doing all of those things, working with my colleagues to make sure we don't over-prescribe, we prescribe correctly, we have good prevention where we can. Do we really need to make this a special subject for nurses to take hold of? If I give you an example in relation to probiotic prescribing, we all have a policy, therefore, whether we agree with it or not, it should be what we stick to. But every day, part of my role within the multidisciplinary team is to argue people to prescribe that. I prescribe it myself. It doesn't seem a very difficult thing. Do we really need to have this as a specialised topic on our nurse training? Is it not really just part of our everyday job to ensure that we look after the environment, but we look after our patients in a preventative way to prevent infections?
So I think that exemplifies that tension between learning about the concept and the label. You know, do you do AMS? Do you know what it is, or do you practice the components of it? And again, maybe that the next stage, this is stewardship 3.0, maybe you practice optimal patient care that includes not misusing antimicrobials just because it's a waste and it's not appropriate and it's not optimal care. So regardless of whether it's called stewardship or not, if you're not prescribing appropriately, if you're not taking samples appropriately, if you're not administering medication appropriately, it's not patient safety, patient quality, rather than this special label of stewardship. So, but I do think that if we are teaching stewardship, we have to teach the whole component or the whole concept as a package. And that was one of the findings from our study, that students were learning about the components, but they were not being told this is antimicrobial stewardship. And I think that fragmentation then is reflected in clinical practice, where we don't see the whole process, the implication of each step. They're not taking a sample at the right time, they're not advocating for the right duration, they're not advocating of a switch to oral therapy when patients are getting better, because we don't see the sort of the coordination of each step, because we didn't get it taught in that way. So I think it may be necessary to still focus on this is stewardship, but it may be the next stage we just call it this is optimal patient care or optimal care, or I don't know, some sort of like next generation label that I'm sure it will be there.
Thank you. Got one last question then. And then
Yes, Neil will know that when we asked the nurses at the hospital about how they perceived their role in antimicrobial stewardship, they were very enthused. But the barriers that they perceived, apart from time and education, one of them was very much about that hierarchy and that challenging the prescriber. And I just wondered, this is going to be a generalised response you will give, whether you see that as a nurse perception problem or a medic's attitudinal problem, in terms of, is it the nurse perceiving the medics aren't going to take their advice, or is it really that the medics won't want to take their advice? Accepting you've got both represented in this audience, Enrique.
But I mean, more than that, I think back in the 50s already Goffman had spoken about the hierarchy of doctors and surgeons. So I think that the fact that exists and now we can see it related to antimicrobial stewardship is probably not new, and we have dealt about the topic of hierarchy in many other areas before. Let's not forget the hierarchy also exists within nurses and exists within any profession and any organized group or any organized human group. But perhaps there are better ways of trying to address practice that may not be optimal, and perhaps focusing on quality and cost-effective quality care, maybe a much better approach than the usual, your prescribing is wrong. And again, let's not forget that prescribing is not an exact science, and there are uncertainties, and humans deal with uncertainty, trying to gain certainty, and prescribing an antimicrobial may just simply give us that sense of certainty, and again, we've got plenty of evidence. But I think that the hierarchy issue is not new, at least in sort of clinical practice. But again, interesting, time and education. If you ask your nurses, how many of these tasks do you do every day? You may find surprising how probably 80%, and that was the result of the African survey we conducted, 82% of nurses said, yeah, I do most of them. But when we said, do you do stewardship, about 30% of them said they did. So maybe that you are witnessing the same situation. And time and workforce, yeah, that's one of those wider determinants, isn't it? And perhaps if we were to influence them, we may have benefits down the line. But yeah.
Thank you very much. I think we better sort of leave it there and break for lunch. So can we all thank Enrique? That's brilliant.